Thanks, Deepak. After that last talk, I'm feeling very stressed and want to take some of those breaths now. Do you want me to finish your talk? Here I am. Okay. Change of pace. I don't see a lot of grey hair out there. My interest in this topic goes back a few years when the College of Intensive Care asked me to assist with drafting a policy about ageing intensivists. I don't know whether they were trying to tell me something, but I got involved in that, and after I'd reviewed the literature and talked to a couple of experts, one in particular, I thought I had enough to write a paper, so I wrote a paper and it was published in the Medical Journal of Australia. So that's where I kind of learnt about this stuff. And of course it was motivated by self-interest. And it's customary to begin talks with a conflict of interest statement, so I should declare my conflict of interest. I am an ageing intensivist, and all my statements and opinions should be viewed in that light. So there are various issues around people getting older, and I've categorised them in this way. So there are issues around the workforce. Are old people clogging up the system so that young people can't get jobs? Can old people cope with the work and the stresses that Chris has talked about, as well as young people? And what should we do with them, or should we simply have the view that if you can't stand the heat, get out of the kitchen? And then there's issues around competence. What happens to people's ability to do this kind of work as they get older? And there's some data around that I'll briefly touch on. There's health concerns, so what are the effects on the individual about continuing to do this stressful job when you're older? And lifestyle. What about your life? What about the other things that you might want to do with your life? So they're the kind of broad areas. So let's look at doctors in general and their ages. And you can see that this is 2015 data, and you can see that there's a significant number of doctors, particularly men, who stay in the workforce over the age of 65. Women less so, but there are thousands of doctors in Australia still working over the age of 65, and even a significant number in the hundreds working over 75 years old. And this is the hours they work, and some, not entirely surprisingly, until about 65, most doctors tend to work pretty much full-time, 40, 50 hours a week. Women somewhat less than men, for reasons that we could all guess and discuss. And over about 65, we do start to reduce our time at work, but not perhaps by as much as you might think. Okay. According to the Australian Institute of Health and Welfare in 2015, if you look at the college data, the data is somewhat different. I'm not sure why that's so, but according to the Institute of Health and Welfare, there's 558 intensivists in Australia in 2015, and their average age is 47 and a half years old. 38% over 50, but notice that there are 20%, so 1 in 5 is over 60. Okay, in terms of our own data that we have about the workforce, the data's getting a bit old now. Felicity Hawker did a major survey in 2009. And interestingly, when she asked intensivists how much longer they intended to keep working, the average for intensivists over 55 was that they intended to keep working in intensive care for about 2.5 more years. But that's not what they do. And the factors that they cited as to why they wanted to give away intensive care were all the things that we would imagine and that have been referred to in some of the earlier talks. Things like callback, being on call, after hours, shift work, and so on. Interestingly, South Australia was the oldest state at that time for intensivists, and a quarter of the intensivists in South Australia at that time were over 55. I'm sure that's all turned over now, and probably they're all young because the old guys have all shuffled off. What happens to older intensivists? Very much the case that older intensivists tend to reduce their public hospital workload, but they maintain the private hospital for obvious reasons. Private hospital is easier work and pays more money. And people at that stage of their life want to top up their super and other things like that. And that's potentially a problem if you think about it, because the place where you want to be as you get older is in a place where you're surrounded by lots of other people. There's lots of peer review, lots of people to help you. In the private hospital, you're much more alone. Far fewer people actually watching what you do and assessing what you do. So while that's what we all do, and I'm guilty of this myself at this stage of my life, it's arguably not a good approach. It should be the reverse, really. Okay, doctors' health. Doctors are generally a pretty healthy bunch of people compared to the community at large. We tend to look after ourselves, we get less cardiovascular disease, we tend to screen better for cancer, that sort of things. But there are some things that we have problems with as a profession. We have problems with mental illness, particularly depression. We have problems with abuse of drugs. We have problems with suicide. And those of you who've been around long enough will know of intensivist colleagues who have attempted or committed suicide. I certainly do. Highest rates of substance abuse, as far as we know, in anaesthetics and emergency medicine, but the data for this, as for many things, is difficult for intensivists because we're a small group, and in most of the databases we're just classified as other. So it's hard to get good data for intensivists. But as best as the data records, anaesthetics and emergency medicine have the highest rates of substance abuse. And maybe that's about stress, maybe that's about easy access to drugs. Okay, so doctors who have problems with these kinds of health issues, they're particularly in these groups. The people who work in rural and remote areas, people who work excessive hours or unable to access leave. Shift work is definitely a factor in these health issues, and doctors who are the subject of medico-legal processes. So if you're being sued or if you're up before the medical board, you're likely to have health issues, particularly mental health issues, and that's not surprising. And some of the stressors, things that have been touched on before, resource limitations, lack of control, lack of autonomy, isolation, particularly for rural practitioners, the demands of keeping up and keeping educated and meeting your CPD points and all those things, changes and demands of administration and the bureaucracy, and changing demands in the community, which are getting higher and are very exacting. Okay, my colleague who assisted me in developing the CICM policy and writing the paper is Carmel Pisa, and she's a New South Wales psychogeriatrician, and she's a very interesting lady, and she, among her other roles, gets to review all the doctors over 60 who get reported to the New South Wales Medical Board. And there's some very interesting findings that she's done, and that I'll share them with you. But she talks about the 4 Ds in older doctors: drugs, depression, drinks, and dementia. You mean to say that there are doctors practicing who are demented? Yes, there are, actually. So Carmel looked at 41 doctors over 60 referred to the New South Wales Medical Board, and she found that depression was a problem in 22%, substance abuse in 30%. Substance abuse, of course, is a common reason for being referred to the medical boards, so it's somewhat a selected population. But interestingly, she found 54% of doctors over 60 who'd been referred to the medical board for problems had cognitive impairment, and actually 12% were demented and still practicing. Okay, so neurocognitive changes, what happens to us as we get older, happens to all of us, starts to happen around 55, 60, but there are very wide confidence limits. Okay, so it's extremely variable and therefore very individual. But things that happen, there's a decline in fluid intelligence, the capacity to think adaptively and apply critical reasoning. Processing speed. So think about both of those two things in the light of the talk that Chris just gave and the guy standing there trying to do that difficult intubation. That kind of performance declines. And it happens to all of us. It will happen to all of you. There's a decline in episodic memory, which is interesting. So we're not so good at laying down new memories, and therefore we're not so good at learning from experience. Again, the sort of things that Chris referred to in his talk about stress and learning from stress. So that kind of ongoing education is harder. Then, of course, there are physical things. So hearing goes off, visual acuity goes off, particularly depth perception and colour discrimination, very important, particularly for the surgeons, and a decline in manual dexterity. So all of the things that we are required to do, particularly in very emergent situations, you get less good at from about the age of 60. And I'll show you, so if we look at the data around outcomes and older doctors, quite a lot of data, not from intensive care but from other specialties. A lot of data from surgery. So surgeons over 60, generally almost all the studies that have been done show that they get worse outcomes than younger surgeons. They get worse outcomes for people that are doing, if they're doing simple, relatively simple procedures that they've done all their lives, they can remain quite good at those. So if you're doing 1 million hernia repairs and you keep doing hernia repairs or grommets, then you're fine. But if you're doing coronary artery bypass surgery or Whipples, your performance definitely declines. Similarly for cancer screening and for some diagnostic work. One of the problems, what happens when you get older is you rely on experience, and experience is basically pattern recognition. And the trouble with pattern recognition is it gets you to an answer quickly, cheaply, with less tests, but you pay the price in fixation error. You tend to remain fixed on a diagnosis and exclude data that goes against your original idea. And again, data suggests from several studies that the younger guys will take longer, spend more money, do more tests, but actually they'll get it right more often. Okay, there's an interesting study around doctors who age well. And this is, what Carmel did with this was she asked the younger colleagues of older doctors which ones they regarded as ageing well and dealing with their ageing well, and then tried to look at the factors that made them that way. First, they had insight. They understood what was happening to them and what their limitations were. Second, they were able to adapt the way they practiced to their age. Third, they thought about retirement and planned for it, and made transitional arrangements. So they moved to retirement gradually. They didn't go cold turkey. They didn't say, I've had enough, and just walk out of the hospital one day. And finally, they developed a lot of non-medical interest. So a lot of these things just make sense. But these are the things to bear in mind as you get older. Those of you here who are getting into your mid-50s, these are the things you want to think about. And as always in life, it's the people who don't have insight who become the problem. Medical Board of Australia has recommended but not mandated regular health checks for people over 70 who wish to continue to practice. It's not mandatory, and peer review. Different solutions. I'll go quickly because I know I'm at the end of my time. You can bring in mandatory retirements. We do that for pilots. We do it for judges. Parts of Canada have implemented competency assessments for people over 70. Then, very important, I think, and very relevant to us to think about is adaptive sustainable practice. And you need to have the facilities provided for you by management and ICU directors and the money available to be able to do this. But older doctors can be very good for teaching, mentoring, some types of administration, research, voluntary work, medico-legal stuff, and so on. It's been suggested and mandated, for instance, by the American College of Emergency Medicine that emergency physicians there over 55 don't do any on-call, and they don't do acute resuscitology. When they're on for the floor, they're always covered by the most senior registrar, basically, to assist them with those emergent tasks, in recognition of the fact that you're just not as good at them. Okay, the CICM statement, very soft. I wrote most of it. It's very soft. It has no teeth, so there's no obligation for any hospital or any ICU to implement this, but it's a recommendation. And despite it being soft, I take some pride in the fact that we were the first college in Australia to formulate a policy for ageing practitioners. There are a number of others now. Get a GP. Don't look after your own health. Don't rely on corridor consults. Self-awareness, very important. Self-monitoring. Have a retirement plan. Understand the impact of ageing on your ability to practice intensive care medicine. Adapt your CPD activity so that you're able to keep up better. And workplace adaptation, and again, you need the assistance of your workplace to be able to do that. Reducing on-call, reducing frontline resuscitation, and promoting some of these other activities. Some of the younger guys may not be happy for you to reduce their call. I don't want to pick up the call of some old bastard and have to do more on call, but you know, you'll get old too, and it'll happen quicker than you think. So that's it. Thank you very much.